It's a tremendous pleasure to be here with my Egyptian pediatric colleagues, and I am very to speak with you today. Whoops, dear. So these are my conflict of interests. We don't need to dwell on these. As I speak before you, one of the things I want to be very clear about is that I am an American pediatrician. So what I'm going to share with you are my experiences. I'm not telling you how to do anything. You are Egyptian, you know better how to handle things in Egypt. But what I'm going to do is share with you my experiences as an American pediatrician. So what will I discuss with you? First, why it's important to talk about HPV vaccination in the context of adolescent care. Secondly, why is HPV vaccination really the responsibility of you and me as pediatricians, rather than with dermatologists or obstetrician gynecologists? And finally, what's the best way to communicate about HPV vaccination? As many of you know, there's an English expression that people who live in glass houses should not throw stones. And one of the things I'm going to share with you is that in the United States, we have done a terrible job communicating about HPV. You realize that this vaccine has been available in the United States since 2006, so 17 years. And yet we have only immunized about 60% of our girls and only about 50% of our boys. If you go to places like Abu Dhabi, the numbers are over 90%, Scotland, 90%, the United Kingdom, 80%. So we have done a very poor job. And one of the reasons we have done a poor job is because we have communicated very poorly. And it's only been recently that American pediatricians and American vaccinators have brought in the science of communication and sociology to help us communicate about vaccination. I'm not going to spend a lot of time talking with you about the epidemiology of HPV. You know this, you can find this, but to suffice to say, this is an extraordinarily common disease. Around the world, as adults, our lifetime risk for everyone in this room of acquiring a genital HPV infection is about 80%. Right? So it's more common to have it than not to have it. It's like having Staph aureus in your nose, right? This is a normal human condition. And there are precious few data in the region, but what we are appreciating is that around the whole region, the prevalence of HPV infection is increasing. Again, lifetime risk probably in the range of 80%, but even in a 10-year period, we've seen that in Egypt, the presence of HPV in cervical samples is increasing dramatically. And of course, what this portends is an increase in cervical cancer and cervical dysplasia 10, 20, 30 years from now. So why is it important that we talk to young people and talk openly about HPV-associated malignancies? It's because HPV-associated cancers occur in midlife at a time which is terribly expensive in the lives of men and women. If you look at cancer diagnoses, you and I are used to thinking of cancers as something that appear in the 7th and 8th decades of life. Cancer is something that happens to people who are old. But for HPV-associated malignancies, the epidemiology is different. Cervical cancer, median age, 50. In fact, more than a third occur before age 45, at a time when women are still caring for children, at a time when women have careers, at a time when women are caring for their parents. So HPV strikes women at a very expensive and difficult time in their lives. Oropharyngeal cancers. In the United States, oropharyngeal cancers are now more common than cervical cancer. In the United States, in Europe, Canada, Australia, HPV is now a man's disease, and it's striking men at a time, again, when they are young. This is not a cancer of old men. Anal cancer, same story, increasingly common. So when you think about HPV-associated malignancies, this is not the face of HPV-associated cancers. The face of HPV-associated malignancies looks like this. These are young people. This is your bank vice president. This is your colleagues at work. These are the people who work in your offices. So why should we immunize as pediatricians against HPV? And here we have a challenge, because this is the first time ever that you and I are being called upon to vaccinate against a disease that we don't see, right? We know measles, we know pertussis, we know mumps, we've seen polio. These diseases we understand. But you realize that HPV is killing more people in Egypt than meningococcal disease, pertussis, and measles put together. So this is a disease that we are being called upon to prevent, even if we don't see it. Now, there are very good reasons for this. And if you look at who does immunize, many people say, well, this is a disease that obstetricians and gynecologists know, that dermatologists know. They should immunize for this. And certainly they understand the disease, and they are used to talking about this. And as pediatricians, we do not own HPV. We don't really understand it. And furthermore, we don't see adult patients. So this is not a disease we expect to see. But our adult colleagues don't see younger adolescents. They don't see males. And immunization is not traditionally a priority of obstetrician gynecologists or dermatologists, right? Obstetrician gynecologists are surgeons. They're interested in being in the operating room. We as pediatricians see young people, and we are great believers in vaccination, right? What defines us as pediatricians is our desire and our ability to vaccinate. Now, one of the things you'll say is that parents will say this to you. And I've heard this around the world in every country I have been in, the United States, Canada. I recently came from Saudi Arabia, and people say, we are a moral people, we are a religious people, we are a righteous people, we're a conservative people, our children don't do this, our children are not sexually active. I hear this everywhere in the world. Do we really need this vaccine? Well, how might you answer this? As I say, I'm just back from KSA. In Saudi Arabia, the rate of cervical cancer is half that of the United States. So viewed as a vaccine, the efficacy of conservative society is 50%. The efficacy of HPV vaccine is 98%. Let's do both. One should not exclude the other. We teach our children to drive, and we put seatbelts on them. And there is no exclusion to continuing to teach our children our morality and our religion, even as we vaccinate them. So how best to talk to colleagues? And you've noticed I put this picture in an elevator. And the reason is because I want you to think about your elevator speech. Right? What can you say between the lobby and the third floor? Because that's how much time you really have. And if you're talking to a government official, you have time between the lobby and the first floor. They don't have a very long attention span. So you have to have your message short, emotional, and on point. And I will say in the United States, we've done a poor job. Clinicians have gone into big, long-winded speeches, typically like this. Mrs. Jones, it's time for your daughter's Tdap and meningococcal vaccine. And then there's also a vaccine against HPV. HPV stands for human papillomavirus. It's sexually transmitted. It causes genital warts. It causes cervical cancer. And by this point, mother is catatonic on the floor. Right. This is not how you do it. We've done it wrong. So we've been talking too much. And this is the thing that you appreciate. When we go to parents and we talk about vaccinating babies, we don't give a lecture on measles immunology. We don't talk about the epidemiology of pertussis. We don't talk about transmission of mumps. We say it's time for your vaccine. It's time to vaccinate your baby. Done. And this is what we need to learn to do. And unfortunately, around the world, led by the CDC, we've said way too much. This is the kind of material the CDC says you should talk about. It takes you 10 minutes to read this. No one can do this. The important thing is this. Parents gain confidence in what you know because you know facts. But when you and I talk, we talk facts. But when you talk to families, what gets people vaccinated is not your knowledge, but your commitment, your relationship with the family, and your ability to communicate effectively. And so what science is teaching us, what studies around HPV vaccine is showing us, is that we should use announcements rather than conversations. We need brief statements that assume that the family wants to do the right thing, and that's vaccinate. And that may be as simple as saying, it's time for Layla's HPV vaccine, which arm? Done. No more. And most families will actually accept this. And then if we have to talk, let's make sure we say the right things. And here we have to appreciate that parents make decisions not on the basis of facts, but on the basis of experience and emotion. This is the human condition, right? Every cigarette smoker knows that cigarettes cause lung cancer and heart disease, and yet they continue to smoke because it's not caused lung cancer or heart disease in them, right? So our experience beats our knowledge. When you and I talk, science is the commodity. We talk about statistics, we talk about facts. You know what a prospective double-blinded placebo-controlled trial is. But we are talking with parents who may not know what immunity means, who may not appreciate what antibodies are. So we have to tell an emotional story. We can't use risk and statistics. What we have to do is talk about how we're going to protect their son or daughter from cancer. This is a poster that the Australians put up early in their campaign. And if you look at this, what do you see? You see a mother who loves her daughter, who wants to protect her daughter. Some good news about cancer. No one's talking about sex. No one's talking about sexual transmission. The message here is that we love our children, and this is how we express our love for our children. And indeed, this is what we do, right? This is my wife the day we brought home our first daughter. And both of us would and continue to do anything we can do to protect that baby. And as my daughters grew up, right, we vaccinated them. And I am proud to tell you that my daughters were the first two young women in Chicago to receive HPV vaccine when the vaccine came out. Why? Because I love them. And one of the things that's important is don't make the vaccine look any different than any other vaccine. Again, the mistake we made, Tdap, meningococcal, and then there's this vaccine against HPV. Instead, what you have to say is this is part of that tray of vaccines that we offer to families. HPV, Tdap, meningococcal, flu, COVID is one word, right? And it's a vaccine just like all the others. And this is why normalization is important. And as you look to HPV vaccination in Egypt, one of the things that will become important as things move forward is using your schools. The United States and Denmark are the only two countries in the world where they have national programs that have not used their schools. And I think this is partly why we have not been successful. Because when you move vaccination to school, this becomes the normal thing to do. The other thing to keep in mind is this. When we make announcements, studies of families show that parents want to do the right thing. You appreciate as a pediatrician that what parents want to hear is that they are doing a good job. Right? And this is part of how we encourage parents. Parents want to do the right thing, and they trust you and me more than they trust the internet, more than they trust the lady next door, more than they trust some crazy celebrity on TV. They trust you and me. And therefore, what we should do, and the data show, is that we should presume that parents want to vaccinate. Because if you don't make that assumption, you're actually wrong. There was an interesting study done in the United States where they asked clinicians, what percentage of parents, how important do parents think that HPV vaccination is? And on a scale of 0 to 10, clinicians thought that parents would rate it as a 5. But when they asked parents how important they thought HPV vaccination was, parents rated it at 9.3. So we as clinicians tend to underestimate how important parents think that HPV vaccination is. Assume that parents want to do the right thing, and you will be correct. And so use announcements. And the recipe is simple. And this has been studied, it's published, it's been now evaluated all around the world. And it's something that I think we should look at here in Egypt as well. The recipe is simple. HPV vaccination is routine practice. We give it for cancer prevention, and we give it today. So how might that look? Layla is now 10 years old. At age 10, we routinely give 3 vaccines to all our girls. We protect our daughters against tetanus, against cancer, and against meningitis. Let's give Layla her vaccines today. And with that, studies suggest that about 70% of parents will say, okay, right there. And you can go on to talk about other important things. Now, if parents have questions, then you can give them information. But the message here is connect before you correct. Make sure that the parents understand that you are listening. Again, good science behind this. I hear what you are saying. I understand that you are concerned about this, that, or the other thing. And if at first you don't succeed, maintain a calm and professional demeanor. You won't always be successful with everybody. But data suggests that with this kind of announcement, you'll be successful about 70% of the time. And if you bring the family back a second time, you will then get the remaining half of about the remaining 30%. Don't take it personally. Don't get angry. Don't demean the family. The parents are trying to do the right thing, and they are looking to you for what the right information is. And so you promise them, we will bring this up at the next visit. And remember too, that as we are seeing a global increase in vaccine hesitancy, your recommendation is the strongest countermeasure we have in vaccine hesitancy. But you have to make that recommendation short, clear, personal, emotional, and absolutely unequivocal. This is what we do. This is the right thing for our children, and you should do it too. So as you think about your recommendations for HPV, be fearless, keep it simple, make it emotional and personal. And many of you I know are professors. Remind your students that immunization is a gesture of love, that we use every opportunity to immunize. And again, we remind our students, our colleagues, and our families, do it today. Thank you all very much.
Yeah. Thank you, Alexander. Very nice presentation, but me and the more attendants are eager to hear about more randomized study, more double-blind randomized study about very crucial and how to clarify this issue to our patients.
So we can certainly talk lots about the science. And there are very good published data here. You are all academics. And if you'd like to talk later about the science, I am happy to do so. But the answer is this: the vaccine works well enough now that Australia, Canada, the United Kingdom, and indeed the World Health Organization is now talking about global elimination of cervical cancer. This is a disease that if we vaccinate in 30 or 40 years, will disappear, and we will not see women dying of a horrible cancer on the edges of their community.
Any question from the floor? So, Dr. Fatin, Professor Dr. Fatin, head of pediatric, Cairo University.
Thank you for your nice presentations. I want to ask about the minimum and the maximum age recommended for HPV vaccinations.
So the question is about the minimum and maximum ages for HPV vaccination. And as you're aware, this varies between countries. In the US, we are now starting immunization as young as age 9 and continuing immunization up through age 26. In Canada, it's actually approved up through age 45. Now, why are we starting at age 9? It's not because we're expecting our 9-year-olds to be sexually active. That's got nothing to do with it. Why are we immunizing at 9? Because at 9 years old, they still come to see you. You and I appreciate that teenagers have very busy lives. And when teenagers come to see us, it's usually for acute care. It's a sprained ankle, they have influenza, they have mononucleosis, that kind of thing. Preventive care fades away as you move into teenage years. So we start immunizing at 9 because they still come to see you and me. That's the most important reason. The other reason is health economic. Remember that if you start the vaccine series before the age of 15, you need only give 2 doses rather than 3. So it makes it less expensive, and that can be a very compelling argument for families. Yes, ma'am.
Thank you for your lecture. I want to ask, if one developed cancer and she is young, she have to take the vaccine?
So this is an excellent question. If there is a woman who's being seen who develops cancer, is there a benefit for vaccinating her? Once she develops cancer, there is no benefit. And that's because the virus is actually integrated. We can't change that. However, there are data for women who, if they present with CIN 1, 2, or 3, so pre-cancer, that if we vaccinate those women, there is a decrease in the subsequent surgery. So there is benefit for vaccinating women with cervical precancer. The other thing, of course, is that once a woman is diagnosed with cancer or precancer, there is regret, there is fear, there is doubt. And this is the time for you and me to say, I can protect your daughter from going through what you are experiencing now. Let's do that.
Excuse me, sir. If we give 3 doses, what is the interval between each dose?
So if we give 3 doses, again, before the age of 15, it's a 2-dose regimen separated by 6 months. If you give it after the age of at 15 or older, then it's a 3-dose regimen, and it's 0, 2 and 6 months. Now, also be aware that there are studies now being done looking at a 1-dose regimen. So this is a very exciting time. But for the time being, what's approved is 3 doses, 15 and older, and 2 doses separated by 6 months before the age of 15. Now, if the patient does not come back for, say, a year, every dose still counts. So if you child doesn't brought back for a year, just give the 2nd dose at a year.
Thank you very much, Professor Dr. Murtada.
Thanks, Professor Alexander, for a very nice lecture. Now we are in the era of anti-vaxxers. How do you manage them in the United States nowadays?
So you're asking a tremendous and timely question. How do we manage anti-vaxxers? And certainly with COVID vaccine, this has stirred up a hornet's nest of anti-vax. I think the answer is this. There's 2 levels of dealing with anti-vax. First of all, there's a government level. And I think when you are beginning to release a program like HPV or some other vaccine, it is required now that the government, the Pediatric Society, and everybody else gets together and plans for what could happen. Plan your press conferences, plan your releases. Now, at an individual level, when we're talking to a family in an office, this is very hard because they are often dealing with misinformation and disinformation. I don't have a magical formula other than to say that this is where your relationship with the family, your trust with the family, and your clear recommendation is especially important. And be persistent and make sure that they understand you are listening.
Did you
Beyond
find
that-
resistance, particularly against HPV vaccine and anti-vaxxers, or they are just resisting everything?
So what we are seeing actually is resistance mostly against COVID and influenza. HPV vaccination resistance has virtually disappeared. For many people now, it's just a regular vaccine. The trouble we have is just getting teenagers to get in to get it.
Yes, just could I present one question? Is there any added value to the HPV 9 over the HPV 4? So if you can enlighten us on that, because
Well, this is an important question because as you're aware, there is a 9-valent HPV vaccine that has been approved. Remember that the 4-valent vaccine has and then 16 and 18, which normally account for about 70 to 80% of cervical cancer. So by adding an additional 5 types, what you're doing is increasing protection from 70% to better than 90%. Now, why did we do this? It turns out that virtually all the HPV disease in men, malignant disease, is due to HPV 16. So this is something we have done to protect our daughters. So what it does is takes protection from 70% to better than 90%. Now, an important question that follows is, should I then wait for the 9-valent vaccine? And the answer is, think of the 9-valent vaccine as seatbelts and an airbag. So if you have an old car and all you have is seatbelts, still wear the seatbelt. So give the 4-valent vaccine until you have the 9-valent vaccine available.
Thank you very much, Professor Alexander, for your elegant and very useful presentation. But I have one small question. اتفضل.
السلام عليكم ورحمة الله وبركاته. I am Professor Dr. Abdul Shafi, Professor of E.U.P. Multiple papillomatosis, laryngeal papillomatosis, this is caused by this virus. We must encourage this vaccine. Please. It affects children, parents, and adults. As E.U.P, I encourage and do propaganda about the vaccine, please. The first point. Second point, we must encourage to be on the path, a straight path, and encourage legal and not illegal intercourse, please. This is, I met a patient suffering from chronic pharyngitis after illegal intercourse and rash due to human papilloma virus, and this chronic pharyngitis since 1 year. شكرا جزيلا مثلا. السلام عليكم.
The man is the source of infection for the girl. Is there anything to prevent this virus from to go to the men? Yes. Is it a sexually transmitted virus?
So the question that always comes up is transmission. And I can say this, that people have come up with all sorts of stories to try and make this palatable. Interestingly, I was in Saudi and one of the other speakers got asked the question, can this be transmitted in a swimming pool? And his answer to the audience is, believe that if you want to, but no. The only kind of transmission, there is rare transmission of mother to baby perinatally, and this is what leads to laryngeal papillomatosis. But the majority of transmission is sexual. Now, that doesn't necessarily mean intercourse. There are other kinds of sexual contact, but yes, this is how it's transmitted. This is also how life is transmitted. This is what we do. This is what everybody does. And this is ultimately what we want our children to do when they are married. So this is just part of the normal human condition.
Thank you very much. And now we close the session and call the professors for the opening ceremony. Professor Dr. Bleedy, Professor Dr. Ahmed Saeed Yunus, Professor Dr. Fatin Abdelaziz, Professor Dr. Fatin Aymara, Professor Dr. Gamal Sami. ده ايه ده هديه دي ولا ايه؟ ماشي. بروفيسور دكتور حامد الخياط، بروفيسور لميا مح، بروفيسور دكتور ممدوح مهدي، بروفيسور دكتور محمد عمر الحسيني، بروفيسور دكتور محمد صبري ابو علم، بروفيسور دكتور منى سالم، بروفيسور دكتور مصطفى السعيد، دكتور نادية بروفيسور دكتور نادية بدراوي، Professor Dr. Ramzi al-Baroudi and Professor Dr. Sana'i. ايوه انا جاي اهو.
انت ما كنتش
جاي انا بقول على الكل عشان انا على بنت البروفيسور
ودلوقتي بعد نهاية الجلسة الأولى والثانية افتتاح المؤتمر. أساتذتنا العظماء اللي هيشرفونا بافتتاح المؤتمر أستاذ دكتور حمد الخياط. اتفضل يا بيه. أستاذ دكتور علياء قطبي. دكتور علياء. اتفضلي يا فندم.
اتفضلي يا فندم. اتفضلي.
أستاذة الدكتورة سناء يوسف.
It only stuck in my stomach for so long. Thank you.
بسم الله الرحمن الرحيم. هنبدأ الاوبننج سيرموني ان شاء الله. طبعا اتشرف وادعو اساتذتي الافاضل. دكتوره امال بشتاوي، اتفضلي يا فندم. دكتوره امال اتفضلي حضرتك.
ربنا يخليك.
الشنطة مسؤوليتها. ايوه حبيبي.
دكتور احمد السعيد يونس، دكتوره فاتن عبد العزيز.